It's a real honor and privilege to invite someone that I think is extremely accomplished in the field of cardiovascular investigation, clinical investigation. Someone has been a friend and a colleague for many years. Michael graduated from the Albany Medical School in 1985, did his residency at the Massachusetts General Hospital, and he worked afterwards, after completing his fellowship at Beth Israel, the Framingham Heart Study. He spent 2 years at Leahy Clinic and joined the Cleveland Clinic in 1993, about the same time when I joined the program. He left in 2007, just a little bit after I left the program. During that period of time, we shared some of the glorious accomplishments of the Cardiovascular Center in Cleveland. Mike and I were interested in cardiac imaging from different perspectives. I was actually quite interested in the technology development and application of novel diagnostic strategies, whereas Michael clearly from the beginning was interested in outcomes research and in the comparative effectiveness of this technology. So when he left to take the position at the HAVI, we all knew that he was going to be very successful, and quickly he has risen through the ranks at the NHLVI, and since 2009, Michael is the director of the Division of Cardiovascular Sciences in Bethesda. It's a real privilege to have you here. Last time I had shared a podium with you, we were debating at a conference, and that was one of the most difficult things I ever had to do.
Mario, thank you so much. That was a really kind introduction. I want to thank you for inviting me to come to this session today. This has been an outstanding symposium. I've really learned a lot this morning. I want to congratulate the organizers for putting this together. Let me start by saying that I have no conflicts of interest to disclose. What I'm going to talk about are my own personal views and do not necessarily reflect the views of my agency. And I am not an economist and I am not a politician. And that's really important, especially now. Okay, what is comparative effectiveness research? It's been all the rage over the last few years, and one way of thinking about it is to look at the three letters. C stands for comparative or a comparison. There's some kind of a contest between different strategies towards treating or preventing disease. E stands for effectiveness or outcomes. And by this we mean the kinds of effectiveness that would be directly relevant to patients and clinicians, such as preventing premature deaths, major clinical events, their quality of life, and costs. And there could be systems outcomes, like how well a system adheres to guidelines. And R does not stand for rationing, although that's what you might think if you read the newspapers. What it actually stands for is research or science. And this can include observational research, synthesis of existing literature, and experiments, which we think of as clinical trials. Now, comparative effectiveness research has received an inordinate amount of attention over the past couple of years because of its prominence in two major pieces of legislation. In February of 2009, Congress passed the American Recovery and Reinvestment Act. This included $1.1 billion specifically allocated for comparative effectiveness research, which was then overseen by NIH, AHRQ, and the Office of the Secretary. This past year, as part of the Affordable Care Act, Congress created a new nonprofit entity called PCORI, or the Patient-Centered Outcomes Research Institute. This just started over the past couple of months, and we'll see where this is going to go. Now, why is there so much interest in comparative effectiveness research? One way of thinking about this is to look at the Institute of Medicine's definition of it, which is that it is a kind of research which is designed to assist consumers, clinicians, purchasers, and policymakers to make informed decisions. So one way of thinking about this is that this is research that is directly relevant to clinical practice or public policy. And the problem is that people notice, people who do clinical practice and people who do public policy, they are well aware of the fact that many of the questions, if not most of the questions that they face, do not have definitive evidence to provide for informed decisions. In fact, in my own field, in cardiology, it's been a group demonstrated last year that only 11% of the practice recommendations that are made by the American Heart Association and the American College of Cardiology are actually based on high-level evidence, that is, multiple randomized clinical trials. And so, therefore, the gentleman in the lower left-hand corner, Peter Orzag, who formerly was the director of the Office of Management and Budget, made a big push for a concerted national effort in comparative effectiveness research when he was director of the Congressional Budget Office. Now, comparative effectiveness research has brought to the fore the intersection between science and policy, although the nature of this intersection has been something that's been known about for a long time. In 1964, Harvey Brooks published a classic paper in which he talked about two ways in which science and policy can interact. One can have science that is for policy, that is, we have policymakers who need to make decisions and they require scientific expertise to make the best decisions. And the example that he gave was nuclear weapons policy. And then we have the issue of policy for science, that is, what kind of policy should be in place that would govern how science is conducted. And this could include things like funding for science. A very recent issue has been stem cells. Now, in comparative effectiveness research, both of these paradigms are in place. When we think about science for policy, the big question is, will comparative effectiveness research be used to determine how the government administers health care in its insurance programs? And then if we think about the other way around, policy for science, we ask questions like, what kinds of evidence should we impose or suggest to the scientific enterprise for primary focus? And then another big question is whether or not government-funded comparative effectiveness research should also include cost-effectiveness research, which has been a bit of a lightning rod as well. In 1990, 20 years ago, Sheila Jasanoff published a very interesting book called The Fifth Branch. This is about the role of people who advise the government on science. And she pointed out something which we all know very well, which is that we need to make decisions. And we need to make decisions today, but unfortunately the evidence that we need to make those decisions may not be there. So there is a presumption that in order to make better decisions, we use science. With science, we will generate knowledge, and that knowledge will make it easier for us to generate better decisions and better policy. But she argues that, in fact, if we look at history, less uncertainty does not necessarily lead to better decisions. Sometimes people have a certain stake in a belief, and they do not want to be confused by the facts. And we'll take a look at that. And so she concludes that this combination of uncertainty and a need for decision-making leads to a forced marriage between science and politics. And forced marriages sometimes don't work. And we see this over the past couple of years in some screaming headlines that have appeared in the lay media as well as in scientific journals. And we'll take a look at a couple of these. One was a piece by Sharon Begley that came out last year about why doctors hate science. And she says, it's not hard to scream when you see how many physicians, pharmaceutical companies, and medical device makers seem to hate science or at best ignore it. These days, the science that inspires fear and loathing is comparative effectiveness research. Scaremongers have morphed the effectiveness research into cost-benefit analysis. The Washington Times said that effectiveness research will threaten lives as government decides who gets a life-saving treatment and who doesn't. Senator Tom Coburn of Oklahoma, himself a doctor, warned of a Soviet-style federal health board that will put bureaucrats and politicians in charge of our nation's healthcare system. I told you I'm not a politician, but I am a bureaucrat. So I'm one of those here. So she goes on to say, you might attribute Coburn's rant to his small government ideology, but I say blame the profession, not politics, but medicine. Doctors have long resisted having science guide their practice. That's obvious from disparities in clinical practices from one region to another. And we're going to take a look at this interesting sentence that she has here about doctors long resisting having science guide their practice. Now, there have been some other viewpoints. This is a piece that Sean Tunis and Steve Pearson posted in the British Medical Journal a couple of months ago, in which they argued that the new emphasis and interest in comparative effectiveness research in the United States is a reason for celebration, that it will lead to better care and better policy. But others don't feel this way. This is Nicholas Mays from the London School of Hygiene. And he says that seen from outside the United States, it's hard to understand why Tunis and Pearson are so optimistic. The very features of the institute, this is this Patient-Centered Outcomes Research Institute, that appear to have been necessary for legislative passage, seem to guarantee its relative powerlessness. So we'll see. Okay, so let's think about this idea of doctors having long resisted having science guide their therapy. Does anybody know who the person is on the left? What? No. That's a good guess, though. So this is one of the most influential people in American medical history, one of the most influential physicians that America's ever had. Benjamin Rush. Very good. So Benjamin Rush, he illustrates this intersection between science and policy. He was a signer of the Declaration of Independence. What may be less well known about him is that he was a powerful proponent for bloodletting, which was a popular therapy. The idea of bloodletting is that if a person has a bad disease, the reason why they have this bad disease is because they have bad humors floating around in them. So to get the bad humors out, you open up one of the veins in the arm, you drain out blood at 1 pint an hour, and everything will be just fine. And this was something which was commonly done, and in fact may have led to the death of President Washington. Now, it turns out that bloodletting was actually a subject of enormous controversy. And more than 100 years before Benjamin Rush, a Flemish physician by the name of Van Helmont published a scathing critique of the profession. And he specifically focused on bloodletting. And this is a piece that was written in 1662. And this is what he wrote. Come down to the contest, ye humorists. Let us take out of the hospitals or camps or elsewhere 200 or 500 poor people that have fevers. Let us divide them in halves. Let us cast lots. One half shall fall to my share and the other half to yours. I will cure them without bloodletting, and you do whatever you do, and we will see how many funerals we shall have. I'd let the reward or contention of the wager be 300 florins deposited on both sides. Here your business is decided. Well, here's my whole talk. This lays out the whole debate on comparative effectiveness research, and this was written 350 years ago. It's a contest. There are winners and there are losers. The stakes are high. We have to take out people from representative populations. We need large sample sizes, and as is typically seen in clinical trials, whatever sample size you start with is too low, and you have to go up. So in this case, he started at 200 and went up to 500. You have to cast lots. You have to randomize. It is the only way that one can make a fair comparison. You need to have clearly defined interventions, in this case, bloodletting or not. You need to focus on outcomes, and in this case, the outcomes were funerals. And now, the next part of this is, which is particularly dear to me as a bureaucrat working in a federal funding agency, is that you have to pay for this. And so in this case, this trial cost 300 florins. And then the final line here, your business is decided. This is business. And because this is business, the stakes are very high. So anyway, it took about 150 years. And a group of people decided to go ahead and do a clinical trial. This was done by Alexander Hamilton, not the American Alexander Hamilton. He was a Scottish surgeon, and he and two of his colleagues arranged a trial in which they took patients who were admitted to their hospitals, and they admitted them to their services in the order in which they appeared. So they would be admitted to service A, B, and C, according to when they showed up. And they agreed that on one of the services, the doctor could do bloodletting as much as he wanted to, and on the other two services, they would treat the patients the same, but they would not allow bloodletting. And what was observed, there were 366 patients enrolled in this trial, and what was observed was that the death rate in the patients who were admitted to the non-bloodletting arms was about 1%, but the death rate in the bloodletting arm was 10%. There was a tenfold increased risk. There's a hazard ratio of 10. So they published this, and what often happens when you publish something that goes against what people want to hear is that nothing happened. So much so that over 100 years later, William Osler wrote that during the last few decades, we have certainly bled too little, and he continued to recommend bloodletting as a primary therapy for respiratory infections as recently as 1928. Now, you may think about bloodletting and say, well, it's an interesting historical curiosity, but what does that have to do with anything? And what does that have to do with the idea of doctors resisting science? But in fact, there are many modern examples of bloodletting. And by modern examples of bloodletting, I mean therapies or strategies that were widely adopted, that were accepted, and yet when they were finally rigorously assessed, they turned out to be either useless or even harmful. And these include thalidomide, hormone replacement therapy, vitamins for preventing cancer or cardiovascular disease, bone marrow transplantation for metastatic breast cancer, PSA screening for prostate cancer, antiarrhythmic drugs, which were supposed to save lives and actually wound up killing people. And now I'm going to go into the next story, and the next story is about the use of stents after myocardial infarction, after a myocardial infarction is completed. So here's story number 2. This is a more recent one. And the question here is, let's say, God forbid, you've had a myocardial infarction. For whatever reason, you didn't get your vessel opened during the early stages. You're now 2 to 3 days out. You're feeling just fine. You're doing just fine. Do you want to have the angiogram on the left, or do you want to have the angiogram on the right? So I think, most people would say, I want the one on the right. And in fact, there were some observational studies that were done in the 1990s showing that people who went home with an open coronary artery did better. Most of the time, the reason why the artery was open was because a doctor went in and blew up a balloon or put in a stent, and sometimes the artery opened up spontaneously. And so this led to something called the open artery hypothesis. And I remember when Mario and I were together at Cleveland Clinic, and I used to attend in the coronary care unit a lot. We talked about this a lot, and we believed it, and it had to be true, and it was so obvious. But there were some researchers who questioned it and who suggested that we should actually subject this hypothesis to a trial. And to make a very long story short, the Boston Globe summarized what actually happened. When researchers tried to organize a randomized study of the benefits of angioplasty for patients who had suffered a heart attack 3 days or more before, they ran into a problem. Many doctors were so convinced of the value of this procedure that they thought it would be unethical to assign any patients to the control group that would not get the artery opening procedure but would only get medical therapy. But the researchers persisted, and with heavy support from the National Heart, Lung, and Blood Institute, they did their project. After 4 years of work, examining 2,166 patients, they came to an unexpected conclusion. Here we see another example of doctors resisting science in medical practice. And here's what the result was. This study was run by Judy Hockman, whom many of you may know. She's at NYU. And what was found was that, if anything, the patients who were randomized to get stents did a little bit worse. Now, the good news here is that, unlike the case of bloodletting, it took a little bit less than 150 years to get the trial done. It took about 10 years. And it took a little bit less than 100 years to convert this into practice. About 1 year after this trial was published, the American College of Cardiology and the American Heart Association issued a new guideline saying that in this particular setting, percutaneous coronary intervention is not appropriate. So in some respects, this is a success story, but it also illustrates some of the major problems. And here's the third story. This is ALL-HAT. ALL-HAT was one of the largest blood pressure trials that was ever done. And in this trial, patients who had high blood pressure and were at risk for cardiovascular events were randomized to receive a low-dose diuretic that cost essentially nothing, or to receive a more modern but more expensive calcium blocker or ACE inhibitor. They were followed over time. Turned out there was absolutely no difference in their outcomes, and in fact, for some of the secondary outcomes, if anything, the patients who were randomized to diuretics did a little bit better. And this trial has had very little impact on clinical practice. So, 3 stories. We have the story of bloodletting, the story of stents after myocardial infarction, and the story of ALLHAT. In the case of bloodletting, it made a lot of sense. The science made sense. The biology seemed right, and there was a strong professional interest. And when I say a strong professional interest, I also include a strong financial interest. Doctors made money by bloodletting people. It took a very long time for a trial to get done from the time that it was initially called for, and it took a very long time until there was a change in practice. If we think about stents after myocardial infarction, it also made sense. The science seemed to be right, and there was a strong professional interest. Doctors some doctors like putting in stents, and they get paid for it. We saw a case here where observational data seemed to support the hypothesis, and yet the observational data failed. It took a long time to do the trial. It took 10 years to get this trial done, but fortunately it took a short time until there was a change in practice. And then the ALLHAT blood pressure trial also made sense biologically. There was a mixed interest. From the point of view of companies that made the drugs, they had a very strong interest in this. Doctors had a less strong interest in this. It took a long time to do this trial, and it led to very little change in clinical practice. Now, these 3 stories raise questions about whether or not medical services provide value, and whether or not they're worth the cost. And so any discussion about policy and comparative effectiveness research has to touch on costs. So we all know this. Our health care is costly. On a per capita basis, the United States spends more money on health care than any other developed country in the world. We are way ahead of Switzerland, France, and Japan. And our health care is excessively costly. It's not simply a matter of the fact that we are a wealthier nation and that we have a greater GDP. For our level of GDP, the amount of resources that go into healthcare is dramatically higher in the United States than any other developed country. So we are an outlier. Now, why may this be? There are lots of reasons for this. This is a complex story, but one reason is that inputs into healthcare are excessive and pricey. The United States has the distinction of doing more CT scans per capita than any other developed country in the world. And it's not only that we do more CT scans, but we pay more for them. We actually pay about 10 times as much per CT scan in the United States than the Japanese do, even though the technology is pretty similar. Now, at the same time, the value of all these extra resources going into healthcare has been questioned. These are data from OECD looking at life expectancy at age 65. So for those of us who are interested in chronic disease, this may seem to be a reasonable metric. The dark blue lines are women, and the light blue lines are men. And what we see here is that, if anything, men and women who reach the age of 65 in the United States have maybe a slightly lower life expectancy than their counterparts in countries that spend a lot less for health care. Now, on top of this, the spending for healthcare within the United States is highly variable. This is something that may be familiar to many of you. This is the so-called Dartmouth Atlas, showing that the resource intensity of healthcare in different regions of the country varies enormously. And one may be 10 times more likely to get a coronary stent in one part of the country than in the other part of the country, all other things being equal. And the Dartmouth group published this paper in 2003, in which they looked at mortality rates and predicted mortality rates after myocardial infarction according to whether or not people got their health care in regions of the country that spent relatively little or regions of the country that spent more. So here people who lived in parts of the country that spent relatively little, their mortality rates at 30 days and at 1 year were essentially the same as those people who lived in parts of the country that spent a lot more for health care. So when you put all this together, what you're seeing is that we seem to be spending an awful lot for health care, and yet it doesn't seem to be translating into better health. And even within the country, we see that those regions that are spending a lot more for health care don't seem to be producing better health. So why is it that healthcare costs are so excessive? Well, one explanation that's given is that the population is aging, and that's certainly true, but that's only a small part of this. And it's argued that really the major driver for increased healthcare costs are new technologies. But the problem with these new technologies, as Peter Orszag pointed out in his CBO report, is that there is only a limited amount of evidence about which treatments work best for which patients, and whether the added benefits of more effective but more expensive services are sufficient to warrant their added costs. Yet, current practice tends to adopt more expensive treatments even in the absence of rigorous assessments of their impact. Now, I agree with this, except that I don't think this is just current practice. If we look at bloodletting and thalidomide and hormone replacement therapy and antiarrhythmic drugs and stents after myocardial infarction and more expensive antihypertensive drugs, this is not just current. This is something which is deeply ingrained within our profession and has been true for a very long time. Okay, so now we enter the PCORI so-called PCORI era. This is this new patient-centered outcomes research institute, which has been created by the Affordable Care Act. And this is going to be an interesting story to follow. This is an institute which is not governmental, but it was established by Congress. It is not profit. It's not for profit. Most of the people on its governing board come from the private sector. Some of them are people you may know, people like Harlan Krumholtz. The head of it is Gene Washington, who's the dean of the UCLA Medical School. There is some government representation. The director of the NIH sits on the board of governors, which means that I have a lot of work to do. And the director of AHRQ also sits on the board of governors. And the question is, how are we going to approach this? So Francis Collins and I posted this piece in JAMA a few months ago in which we thought about what are going to be some of the major challenges in comparative effectiveness research over the next few years. And we identified 5 major challenges. One is how do we establish criteria for priorities? How do we know what projects we should actually do? In a way, this gets at what Tom Farley was talking about this morning. How do we, where should we actually invest our resources? And typically we think about public health needs, we think about scientific opportunity, we do research where the technology now makes it possible for us to do a meaningful project, and we also have to think about stakeholders. And that's been the new element here is involving stakeholders in making decisions about priorities. So stakeholders include patients, doctors, policymakers, payers, companies that make drugs or devices, patient advocacy groups. There are lots of stakeholders, and the problem is, and we'll take a look at this in a second, is that stakeholder interests may not necessarily coincide. How are we going to do affordable pragmatic trials? And we'll talk about that. Can we ever trust observational data? We have been burned with observational data. I showed you an example with the occluded artery trial. Perhaps the most famous example is hormone replacement therapy. Implementation research. Will improved knowledge actually lead to better practice and better policy? And how can we actually study that process? And then what about personalized medicine? There are a number of people who seem to think that comparative effectiveness research is inherently a threat to personalized medicine. We held a big symposium at the NIH a couple of weeks ago to try to diffuse that myth. Okay, stakeholders' interests may collide. This is the best definition of conflict of interest I have ever seen. This is Upton Sinclair. Upton Sinclair was a journalist, a writer. He was a politician. He was not a very good one. He was a great writer and author. He wrote the book called The Jungle, which led to the development of the Food Act in 1906. He ran for governor of California, and his opponent got maybe 10 million votes, and he got about 2 votes. This is what he said after the election. He said, "It is difficult to get a man to understand something when his salary depends upon his not understanding it. If my salary depends upon doing bloodletting, I really don't want to know whether or not bloodletting works or not. If my salary depends upon doing bone marrow transplantation in women with metastatic breast cancer, I don't want to do a trial because I really don't want to find out what the answer is." And we saw the same thing with the occluded artery trial, where people who were opposed to the trial, who didn't really want to know the answer, criticized it for being unethical. I think this is a big, big problem, and we have to face it. Okay, now the next issue is pragmatic trials. A pragmatic trial is a trial which is going to be most relevant to real clinical care. When I was a young junior attending, I used to talk a lot with my uncle. My uncle was a cardiologist, and he's the reason why I became a cardiologist. And I would act like I was a real smart aleck, and I knew better than he did. And I would say, well, the trials show this, and the trials show that. And he would say, Michael, I don't know what you're talking about. I never see these patients. You can sort of understand where he's coming from. And so this has led to an increased push for pragmatic trials. And this is a construct of what pragmatic trials may look like. And there have been a number of pragmatic trials that have been done. We'll talk about some. Pragmatic trials have broad eligibility. Real patients, patients whom we actually see, like the patients who are being seen in this building today. Flexible interventions. In other words, we don't strictly protocolize what is actually being done. Typical practitioners, the people who are actually going to be using the intervention in question, not the best trained doctors or the best trained nurses. A usual care comparison. No follow-up visits. Now, this is a really important one. You know what? When I worked at the clinic, I loved to enroll patients in trials. And you know why? Because that way they got taken care of. I didn't have to worry about them. They would see a nurse practitioner who would dot all the I's and cross all the T's. Everything would be perfect. They would be happy. I would be happy. But the problem is that doesn't reflect what happens in real life. In real life, follow-up happens much, much less frequently. An objective clinical outcome, that's standard to effectiveness research. Usual compliance. We don't go out of our way to assure high levels of compliance because guess what? People generally are not compliant. Only 50% of patients who have established coronary disease actually take their statins. And so that's real life. And we want to see whether or not an intervention works under real life conditions. So this will now lead to my next story, which is the story of GISI. GISI, this was a group of Italian investigators who got together in the 1980s, and over a period of 20 years, they oversaw some major randomized trials. And perhaps one of the most important trials they did was the GISI-1 trial. This was a trial of nearly 12,000 patients in Italy who came to an emergency room with complaints that suggested that they were having a heart attack. And they were randomized to get streptokinase, which was a drug that had been available for a long time and cost essentially nothing, or to get control, and then they were followed to see who died. And it turned out that the patients who got streptokinase had a substantially lower mortality rate. And this opened up a whole new era in cardiovascular care. You know how much this trial cost? It was a trial, a mega trial, 12,000 patients. It was published in The Lancet. It has had an enormous impact on practice. It cost 350,000 euros. It cost less than an R01. The cost of the trial was about 30 euros per patient. In fact, they didn't even have the money when they started the trial. They took out a bank loan. It's like, go to the bank, get a mortgage to do a clinical trial. Then they did a series of other trials. They did some factorial trials on thrombolysis and subcutaneous heparin, on some dietary interventions, the use of ACE inhibitors after myocardial infarction. And what's interesting is that all of these trials were cheap. The typical cost was in the neighborhood of 200 to 300 euros per patient. The most expensive trial was a statin trial in heart failure, and even that only cost about 3,000 euros per patient. Now contrast that to what's going on today. This is a piece that Rob Califf and his group wrote looking at the costs of phase 3 trials for acute coronary syndrome and heart failure, and they based this on doing some surveys of people in industry. So they imagine an ACS trial with 17,000 patients, or a heart failure trial with 14,000 patients, and the cost of these would range from $80 to $140 million. The case report forms would be 20 to 78 pages long. The case report form for the GISI-1 trial was 1 page. 1 page. Now we're talking about case report forms that are 50 to 80 pages long. The cost per patient would range from about $5,000 to $10,000. And then they went through an exercise in which they said, imagine that we could simplify the trial. And if we could simplify the trial by doing a variety of things, we could potentially make the trial as cheap as $3,000 to $6,000 per patient. Even this is substantially higher than the GISI costs of $200 to $300 per patient. Now, here are some costs of some trials from our agency, from NHLBI. The costs I'm showing you here are the costs to us, the cost to NHLBI. In some cases, some of these trials also receive some funding from industry. But you can see here that for most of these trials, the cost per patient was in the neighborhood, it was about the same. It was about $5,000 to $10,000 per patient. Now, we have one exception, which is the one on the bottom, which is called the VITAL trial. This is a trial that is just starting now. This is a trial of 20,000 elderly subjects, and they're being randomized to vitamin D or to fish oil. And the idea is to see whether or not these agents can prevent cardiovascular disease or cancer. And this trial is actually only costing us, the NHLBI, about $250 per patient. The NCI, the National Cancer Institute, is spending $300 per patient. So it's costing you, the taxpayer, about $500 a patient. This trial is a very simple, practical, pragmatic trial. Most of the follow-up is being done by mail. Well, one argument that I often hear is that people say, well, we need to have more infrastructure. And if we had infrastructure, that would solve everything. And I know I'm talking here to a CTSA audience. I have to be very careful what I say. But infrastructure is not necessarily the panacea that people think it is. Perhaps one of the best known examples of infrastructure for trials is the cooperative groups, the cancer cooperative groups. To give the NCI credit, they went to the IOM and said, please take a look at our cooperative groups and see what you think. And the IOM put out a rather scathing report. And this was summarized in an editorial in the New York Times saying that the nation's most important system for judging the clinical effectiveness of cancer treatments is approaching a state of crisis. That is the disturbing verdict of experts assembled by the National Academy of Sciences to review the performance of clinical trials sponsored by the National Cancer Institute. So while we certainly hear the arguments for infrastructure, it's not that simple. So how can we simplify and improve trials? And none of these are original ideas. One is to fit trials into practice and to clinical information technology. Fold the trial enterprise into routine clinical care. The GISI investigators did that beautifully in their trials of patients with acute MI. The VA right now is doing an interesting experiment with so-called point-of-care randomization, where the doctor would be taking care of the patient. They would put in an order into the computer, and the computer would spit back, oh, for what you're trying to do right now, there is a trial. And we'll randomize the patient right now and go ahead and consent the patient right now if that's okay with you. All you have to do is push a button that says yes. Limit the case report form length. There is no reason why case report forms need to be 20 to 100 pages long. 1 to 2 pages most of the time is just fine. But that represents a major cultural shift. We have to think about clinical trials as focused experiments and not as massive exercises. And applying metrics for performance. We sometimes refer to this as wedding planners. When you go to a church or a synagogue to get your child married, typically they'll say, well, we use certain wedding planners or we use certain caterers and we hold them up to very high standards. And if they screw up, they lose the business. And we'd love to see something like that. This is my own personal opinion, by the way. Now, operations, how do we run trials? Decrease monitoring. Having to do these monitoring sites where you look at every single record is totally unnecessary and adds almost no value to the trial. It makes more sense, for example, to use statistical analyses to find outlier centers and see what's going on. Do research into the process of clinical trials. And this is something that I'm happy to say we're going to be doing at NHLBI. We're going to be looking at supporting research into research. And there's looking at we're going to fund research into projects that look at the processes by which clinical trials are done, try to figure out ways to make them more efficient and simple. Central IRB. Now, I spent 14 years on an IRB, and I remember wondering, why are we looking at these protocols that 9 million other people have already looked at? What are we possibly adding to this? There's no reason why a trial needs to get 200 reviews or 500 reviews. One really good review is enough. Jerry Menikoff, who's the head of OHRP, published a beautiful piece in New England Journal a few weeks ago in which he argued very strongly for central IRBs. And then in design, we should see more factorial designs where you're testing multiple things at once. Get 2 trials or 3 trials for the price of 1. And then there are other approaches like cluster trials and adaptive trials. These are various designs by which we can do trials potentially more efficiently. Now, here's some provocative ideas from Salim Yusuf, who many of you may know. He worked at NHLBI for a long time, and now he's at McMaster. And he wrote some ideas about how we can rescue the clinical trial enterprise. He also argued for infrastructure for the development and sustainment of networks. He called for a need to minimize bureaucracy and overregulation. And now I'm a bureaucrat, and I would agree with that. He complains about unrealistic and excessive financial expectations of investigators and large overheads by institutions that appear to consider trials commercial activity. I once was on a phone call with him, and he told me about a big mega trial that he wanted to do for a few $1 million. And I said, Salim, how can you do a trial that big for a few $1 million? And he said, Michael, this is not the United States. And then he also complained about wasteful practices, especially by industry, which can double or triple the costs. All right, now the next issue, the next challenge is, can we ever trust observational data? And this is a whole, we could spend all afternoon talking about this, but I think this is a key line to remember. This is from David Sackett, who many of us might consider to be a modern father of evidence-based medicine. And he argued that the reason why so many doctors did so many really dumb things, like bloodletting, is that it was because they were brilliant observers of humans but not experimenters upon them. And observation by itself provides insufficient evidence of the value of a treatment. Science ultimately is about experiments. That's the fundamental unit of science, is the experiment. And let's remember what Sharon Begley said, that doctors have been resistant to science for a long time. And here's David Sackett essentially saying the same thing. Okay, now the final issue is, will it actually help to generate all this knowledge? Will all this new knowledge actually lead to better clinical practice and better policy? And it may be argued that, unfortunately, the answer may be no. Now, this is a piece that Zeke Emanuel and Victor Fuchs wrote in JAMA, where they discuss the phenomenon of overutilization, that is, use of services for which there's no good evidence that it actually leads to benefit. And they argued that there are a number of factors that lead to increased utilization, overutilization in the United States. One is physician culture. We're all trained, especially specialists, we're all trained to be thorough. Fee-for-service incentives. There was a really neat piece about androgen deprivation therapy in last week's New England Journal that showed what happened if you cut down the fee for a particular strategy. Well, guess what happened? It was prescribed a lot less often. Aggressive marketing of devices and drugs by the companies that make them. Fears of malpractice, and this is a very real problem. I have been sued. I know exactly what this is like. Patient preferences for high technology. In the United States, we just love high technology, and we assume that if it's new and glitzy, it has to be better. Direct-to-consumer marketing. Doc, I want my Lipitor. And cost shielding by third-party coverage. Patients don't see how much some of these interventions actually cost, and neither do the doctors. Now, what's interesting about this article is that nowhere in there is absence of scientific evidence. They don't even mention it. And Zeke Emanuel works at the NIH. Okay, so my final thoughts about comparative effectiveness research in the era of health reform is that we face a lot of challenges. The controversy surrounding this fundamentally deals with whether or not medicine is at its heart a scientific profession. And the controversy surrounding it is something that long precedes health reform, and we see it in the stories of bloodletting and percutaneous coronary intervention after myocardial infarction and blood pressure treatment. Still, we face a number of major challenges. We have to make decisions, even though the evidence is not there. We have to face the fact that we're dealing with multiple stakeholders, and these stakeholders all have stakes. They all have dogs in this fight. And the stakeholders include the scientific community, includes us, and it also includes patients, clinicians, payers, and policy. And somehow we're going to have to confront the fact that that their stakes may not necessarily lead to better patient care. I think one way of thinking about this is, who is the number one stakeholder? Who is the stakeholder who should have priority over everybody else? And that's the patient. We should rediscover the large, simple, practical trial. This is going to be, I think, one of our top priorities over the next 5 to 10 years, and this will determine whether or not the United States will remain a major player in clinical trials. Or is this going to be outsourced, kind of like everything else? Will knowledge mean better practice and policy? I don't know, and there's certainly evidence to suggest that maybe we shouldn't be so optimistic about this. And finally, what are the rules of the game, and who is going to determine them? And that's something which time will tell. So anyway, I hope you found this interesting. I hope you enjoyed the stories, and thank you all for coming.
Great job. Let's see what they...
Thank you, Michael. That was really incredibly energizing, and I know the crowd wants to ask a lot of questions, and there's a poster session. But and having heard your prowess as a debater from Mario, I don't want to really engage. But do you think the practical, low-cost therapeutic clinical trial is feasible in our current fragmented system? All three examples, Italy, Canada, and the VA, represent some equivalent of a single-payer model. And just your thoughts about that implementation challenge.
Yeah, I think that's a really important point. And in fact, most of the low-cost trials that we're looking at are occurring within integrated healthcare systems. And the fragmentation of care, in particular the fragmentation of information, is a major problem. Now, having said this, Joanne Manson is doing this vitamin D trial, and that is not within an integrated healthcare system. And she has figured out a way of doing this trial for very low cost, and she has a history of doing trials for very low cost. So it can be done, but I agree with you. I think the challenge is quite a bit greater because of the fragmentation of the system.
It's a terrific talk. Thank you. I wonder if these kinds of trials might also circumvent another problem that we have. Vioxx was first rolled out in clinical trials in select patients, and then when applied to the general population had cardiovascular side effects. This morning's New York Times talks about Fosamax for those with severe osteoporosis, and then when applied to those with pre-osteoporosis produces jaw necrosis, etc. So does one get a more real-life look, and will that change the acceptability by physicians? Because, all you need is one or two of those trials and or a bad result in a patient you're caring for, and you say, to heck with the data. I'm going to go with my gut. I don't need the trials. They're wrong.
Right, and I think that's a really good point, and that I think gets to the heart of what my uncle was telling me when I would say, I would quote a trial, and he would say, well, I don't see these patients. It is difficult to do trials with real patients because real patients are messy. Real patients have comorbidities. Real patients aren't compliant with their medications sometimes. And so it makes it more difficult it makes it at least emotionally and intuitively more difficult to do. And yet, you're absolutely right. It then makes it much easier to interpret the results of the trial and then potentially apply those results. In the GISI trial, the first trial of thrombolysis, the inclusion criteria there was one. It was that the doctor thought the patient was having a heart attack. That was it. And so it made it very easy to implement that into real care.
I thought you made some very intriguing points about how research, even getting this good, high-quality comparative effectiveness research, may not change practice. But since you quoted Upton Sinclair saying one doesn't want to know the things that one's paycheck depends on, I'm going to choose to ignore that. And I'm going to instead ask you about the exciting opportunities to enhance comparative effectiveness research and increase it, and ask you to say how last week's election may affect, if you have a feeling for that, how it may affect the increase we've been looking for in this type of research.
Yeah, that's a really good question, and I mean the honest answer is I don't know. Nobody really knows what's going to happen. I heard a great talk given a few weeks ago, I think by Fran Burns, and she said that if we're going to move this research forward, what we have to point out is that in a way this is really nothing new. We have been doing clinical effectiveness research for a long time. We've been doing it for decades. And in some cases, we have some really great success stories. Hypertension, hypercholesterolemia, myocardial infarction care. These are defibrillators. These are some incredible success stories. And what we need to be doing as a research community is touting that, is to say, you know, we've had some incredible victories. And these incredible victories have led to better patient outcomes. We saw DCCT this morning, was another one. I mean, we've had some incredible victories. And so we want to point out that despite all the new interest in this, it really isn't anything new. It's rather an increased emphasis, we hope, an increased emphasis in something that we've been doing for a long time, but we would like to do it better, faster, cheaper, and perhaps in with a broader spectrum than we've done before.
I wonder if you would comment on dissemination science, which has shown the importance of opinion makers in the adoption of the evidence. Certainly the pharmaceutical industry has recognized that and does that, and I wonder what role historically it's been stakeholders that have been pushing the science when it was in their interest. Who's going to push it when it's not in anyone's financial interest?
Yeah, well, I guess that's a great question, and my answer to that is the only one who will push it is the government, because the government represents the people, and so therefore it is in our interest. And so actually one of the ways we think about prioritizing projects is we say we want to fund or promote a project which if we didn't do it, nobody else would. So there's a benefit, there's a public health benefit, and it wouldn't happen were it not for the government. Now, dissemination science is a very important part of CER. In fact, the Institute of Medicine identified care delivery as being its #1 priority for CER over the next X number of years. And we have some very nice examples of dissemination science. One project that was funded by NIH looked at delivery, a simple behavioral intervention to improve care of women in labor. And the idea was to increase the use of Pitocin during the 3rd stage of labor and to decrease the use of episiotomy. And this was a low-cost trial. It was a cluster trial where they randomized 19 hospitals to the intervention or to control. They actually wound up looking at about 30,000 labors. So in this very inexpensive trial, they were able to look at a huge sample size. And what they found was that this relatively low-cost intervention dramatically improved care. It dramatically reduced peripartum hemorrhage, and it led to roughly equivalent APGAR scores among the babies. So you have a nice example here of dissemination science, and we certainly, that's something that is high priority, and we like to, and it is an integral part of CER.
Thanks. Mike, great presentation, terrific concepts, and I just wonder if I could get you to expand a little bit on 2 areas. The observation you shared about physicians' resistance to incorporating science strikes me as the sort of equivalent to keeping the government out of Medicare. Mm-hmm. And do we have an opportunity, if we promote the concept of equipoise, and really, it's a concept I think that's important for engaging both clinicians in clinical research and engaging patients in clinical research, and really gets to the heart of when we truly don't know whether one is better than another. And I wanted to relate to that whether it's time to re-examine direct-to-consumer marketing and FTC and FDA interfaces between what's really allowable and permissible in terms of generating both consumer demand and perhaps clinician demand for using some products that maybe haven't adequately been evaluated.
So, Jonathan, I think it's a great question, and we have noticed that for some trials we're having difficulty enrolling people, and we think that part of it is because of direct-to-consumer advertising, that patients know exactly what they want, they tell their doctors exactly what they want, their doctors don't want to resist, and so therefore we can't get them into the trials. Now, another way of thinking about direct-to-consumer advertising is that just as the drug and device companies have used direct-to-consumer advertising to get their patients to use their products, we can do direct-to-consumer advertising to get patients to demand to participate in research. And so that gets to something that Tom Farley said also this morning. And a nice example of this is what Susan Love is doing with breast cancer. What she's saying is, you know what, the biggest impediment to getting patients into trials are the doctors. So we got to get around them. So the way we get around them is we put together this army, is what she calls it, an army of 1 million women. It's more than that now, but 1 million women. And we're going to get them really interested in research, and we're going to get them to demand that they get into research studies, or demand that their daughters or mothers get into research studies. And we could imagine, and this is something that we're thinking about a lot at NHLBI, is if there's a way that somehow we could reach out to patients and to communities so that the scenario would be that the patient comes into the office and the doctor says, well, you've got heart failure, or you've got atrial fibrillation, or you've got angina. And the patient says, Doc, I heard that there's a good trial going on that, and can you get me into that?
I'd like to return to the large, simple study. You are involved a lot in guideline development, as I understand it. Would you be able to develop a guideline based on GISI, or do you need to combine GISI with TIMI and European Cooperative Study to get a comprehensive picture and target the patients better than GISI did?
That's very interesting, and that I think gets into the heart of a major philosophical debate about what guidelines should actually look like. Now, right now I'm expressing my own personal opinion. This is not, okay, do not take this as the opinion of the agency. But I've often wondered about targeted therapy for cholesterol. Where does that come from? Now, there have been a lot of large, simple trials of statins, and the results have been amazing and consistent. It's very clear that for most patient subsets, these drugs work incredibly well. And so I would think that a fairly simple guideline could be written that would say, if a patient has coronary disease, they should be on a statin. And that's it. And it's really all you have to say. And you don't have to follow their cholesterol. You don't do any of that. I'm not the only one who feels this way. Harlan Krumholtz, for example, wrote a nice piece in the British Medical Journal arguing that. Now, on the other side, you've got people who say, no, you really have to tease out, who exactly benefits, who doesn't benefit, and how you monitor them. So I think what your question gets at is a deep philosophical divide about how guidelines should be put together and how we interpret scientific evidence. And I can see the merits of both views.
Michael, the NHLBI has traditionally decided on the merits of a grant based on scientific relevance or clinical relevance of the question, as well as a scientific merits of the proposal. Is there any official shift in policy where cost is going to be considered part of the equation now?
Cost of
the trial?
Oh, well, that's not there's no shift there. I mean, that's something that the agency's been considering has always considered. What we do is that those projects that we consider to be potentially meritorious for funding get presented to our council, and as part of our rules and regulations, any study which involves more than $500,000 a year of direct costs per in any given year has to be discussed in an open council session. And these discussions invariably lead to, is it worth it? Is this, okay, it got a good score, it's a good project, is it worth $10 million? Is it worth $100 million? Is it worth $5 million? And we get into a discussion about that. So that's something that has always been, if we fund a big project, that means that there are a bunch of other projects that won't get funded. If we fund one big project, then we can't fund another big project. That's going to get worse over the next few years because we're anticipating that at best the budget is going to be flat, and many of us are actually planning for major budget cuts, which means that this is all the more reason why if we want to keep the clinical trial enterprise active in the United States, we've got to make the trials cheap.
Show benefit. Last question.
Sort of a follow-up to that question, and thank you for a very interesting presentation, but it really gets to, are there, as you've sort of suggested, comparative effectiveness research really is a different way of looking at research, conducting research, and it's very different from what the NIH is used to doing and funding. So to what extent within the NIH do you think that there's a potential for a change in the institutional culture for what gets funded and what's given priorities in terms of types of research? Or is this going to just get siloed like many other things?
So that's a great question, and I think that there, from my perspective, I'm seeing that there really is a change. The stimulus bill actually stimulated us. So we now have a high-level trans NIH comparative effectiveness research committee that includes IC directors. We meet once a month. We were charged with making the decisions about how to spend the $400 million that were given to us, and now we're dealing with how we're going to interact with PCORI, and we are having very high-level discussions about where this research fits within the overall NIH portfolio. I would say that, as evidence that there is a truly increased interest in this, Francis Collins enunciated research to inform healthcare reform as one of his top 5 priorities. And this is something that he talks about a lot. He wrote about it in Science, and we hear this over and over again. So I think that things are moving in the right direction. Unfortunately, the challenge that we're facing are tight budgets. And, everybody wants to keep their piece of the pie or anything. What I always hear is that it doesn't matter who they are. Just any person, any specialty, you're not spending enough money on me. And that's only going to worsen. But I do see things moving in a positive direction.
Want to end the discussion here. One, I want to thank our speaker.